Good evening. Sorry for the delay. I was just literally getting back from Austin. Flights were delayed because of the cold weather, but we'll get it done. So thank you for those that have been patient, and I do apologize for the delay. I have a few people that had submitted some questions ahead of time, so we'll go ahead and answer those. So I'm in the kind of the red light room tonight with the Peloton and such. Like I said, literally just jumped off the plane, came straight home, dropped my bags, and trying to find the microphone and make sure it's working okay. So I'll let you guys log on here. If you have any other questions, go ahead and drop them in the comments. But just came back from Austin. Was at the Forever Strong event that Dr. Lyon was throwing. It was outstanding. A lot of great speakers. Phaedrus Koulian, who was the person who actually introduced me to Dr. Lyon. Jason Redmond, a very decorated Navy SEAL, has an amazing story called Overcome, is his most recent book, I believe. And then a lot of other good health and wellness people speaking as well. So a lot of good networking, learned a lot, and I'll be sharing that in my content. And definitely for those that see me at Apollo, you'll be hearing more about that in the office. So, all right, well, let's get to it then. So, question 1, is anything a patient could do to bring in preparation for an appointment with me that's helpful? That's a great question. My team is pretty good about tracking down any old records, but if you have access to prior cardiac testing, including stress test, echocardiograms, heart catheterizations, CT scans, that's always helpful, as well as any type of genetic testing that won't change. If the labs are generally over 90 days, sometimes we'll look at a trend of lipids, but I don't need every lab that you've had for 20 years because we're getting a very comprehensive baseline. And so we'll be reviewing anything that you had in the past, and there's a very comprehensive lifestyle question. So just as long as that's filled out, we'll have a good baseline to start with. Question up. Hello, Dr. Twyman. What continuous glucose monitor do I recommend? The only one I have experience with is the Freestyle Libre monitors. I've done it 3 times, I believe. Works pretty well. It's not going to be as sensitive as the Dexcoms, but it comes at a fraction of the cost of the Dexcom systems. And then basically, unless you're diabetic, you're never going to get these glucose monitors covered by your medical insurance, so you're just going to be buying these out of pocket. There are various kind of like services, that offer these glucose monitors. At our practice, we tend to use a company called THEIA, THEIA. They use the Freestyle Libre monitors, and they have a discounted service when you sign up for like a 1-year membership with them, and then all your data gets dropped off into the dashboard on their website, and you can kind of review it a little bit easier. So usually it's the Freestyle Libres, but if you have access to the Dexcoms, that's even better. I think this was a jet lag question. This is outstanding. So I'm traveling to Thailand from New York in 2 weeks. Any tips on how to best deal with it? This was my story back in 2017, the reason I'm still wearing the blue blocking glasses. So I've done a whole, video. It's going to be in my archives on this, and it's probably on my YouTube channel, which if you just go to YouTube and my name up here at Dr. Twyman, you should be able to search for the jet lag mitigation video. I did one last year when I was flying to Finland, but the same protocol kind of is used for this trip to Asia. There's an app called Time Shifter. It's free for the first time they use it. You plug in your flight itinerary, and it tells you, how to start adjusting your light environment, your sleep environment, your timing of meals, 2-3 days before your trip. It tells you what to do on the plane and then when you get over there. But one way to think about it is that, like, once you're on the plane, just mentally prepare that, you're living on Thailand time. So, I like to wear a GMT watch when I'm on the plane so I can keep my home time and the location time I'm going to. Or just if you're wearing, one watch, just set it to Thailand's time and just start trying to live like that. So if it's nighttime there, sleep on the plane if you can. If you can't, then at least wear the blue blocking glasses. I bring the darker red ones when I'm on the plane and it's nighttime where I'm going. I try to stick to mealtime. That would be where I'm going, not what the flight attendants are serving you. And most of the time the food on the plane is not necessarily that great for you. So I generally bring my own protein bars and snacks, and always get some spring water when I get through security. And then when you get to the location, try to get some bright morning sun the first day that you're getting there. And then earth and grounding is great if you can get access to it, soak up some electrons, and then just try to, take it a little bit easier the first day. You do want to get outside and do some stuff, but try not to overdo it, and then really try not to nap if you can, because you really want to try to get yourself set up to the cycles that of light and dark, and as well as the timing of your meals as soon as you can. But time shifter app, and then just wearing a watch on the plane tells you, what time it is in Thailand, and just trying to live by that time zone. It was just a follow-up question to the jet lag one. So, question: should somebody should metabolically healthy heterozygous FH, which stands for familial hyperlipidemia, individuals be treated with statins? So I'm always going to say this is not medical advice, and it always depends on the individual who's sitting in front of you. And so, you're just giving me information about what is in your blood. I would want to know how healthy your arteries are. So endothelial function, vascular inflammation, hard plaque, soft plaque. If you have plaque in your arteries, then yes, for sure, you're definitely going to be treated. And more likely than not, probably with statins being one part of that toolkit. And then I would be careful about the word metabolically healthy, because what that definition actually means. That just means you're not insulin resistant, okay, but are you getting the right types of fats in your diet, or are you eating a keto diet that's high in saturated fat and you're an apoB4 carrier who hyperabsorbs sterols? So there's a definition of metabolically healthy that does not include just insulin resistance. So you want to look at your arteries, non-invasively. The calcium score, the Clearly scan looks at the coronary arteries. Carotid intermedial thickness scans look at the carotid arteries, and then there's a test that can look at pulse wave velocity and endothelial function. So basically, how stiff are your arteries? If your arteries are stiff or you have plaque in the arteries, you'll definitely want to be working on lowering your apoB lipoproteins. Somebody's asking about niacin for heart health, benefits, drawbacks. I kind of think it's fallen out of favor for the most part. People are on it. I don't necessarily, recommend that they stop it, but it's hard to use because to get to an effect on the lipoproteins, you usually got to get up to 1,500, 2,000 milligrams a day, and often people are going to be having flushing, tingling sensations. Sometimes it's raising their blood sugar, so it's really hard to use the therapeutic dose in some people, and also it's just not that potent at lowering lipoproteins. Now, some people want to take it for lipoprotein little a. It may help a little bit, but is it actually clinically significant? It's never been proven that it does. And so I'm not a huge fan of starting it for everybody. In some instances, people have really high triglycerides, maybe I'll be using it. And there is some data that, it may affect the function of the HDL. So there's no such thing as good cholesterol, and HDL being high doesn't necessarily mean that's good for you. And niacin might change the proteins that are sticking to the outside of the HDL and changing it for the worse. So, so it's one of those ones, it's nuanced, and I don't recommend it for all. Somebody's asking about myocarditis. Will it affect them later in life? They're 47. Heart failure is not my area of expertise at this time. I've not been in the hospital in 4 years. For inpatient consultations, I've been focusing on basically heart attack prevention, hypertension management, and just helping people not have heart attacks and strokes. But myocarditis is an inflammation of the heart muscle, and if the ejection fraction has normalized, how well the left ventricle pumps, then not likely to cause anything later in life. It's the people that had fulminant myocarditis that ended up with ICU stays and then potentially on ECMO and maybe end up getting a left ventricular assist device or heart transplant. Yeah, that's definitely going to be lifelong a problem. But if you had myocarditis and recovered, should not affect you later in life. This is a good question, and it's still in the kind of like debatable zone of what exactly to do about it. Somebody's asking is TMAO, which stands for trimethylamine oxide, associated with heart disease. It's associated, but what to do about it is the big question. So this compound is elevated when the gut microbiome is unable to break down carnitine and choline effectively. So if you eat a high carnitine choline diet, which would be a lot of animal-based products in some instances, but it's also fish, but often the time I see this is when people are supplementing with acetyl L-carnitine, the carnitine gets shuttled back to the liver, and the liver produces this TMAO substance. And this TMAO can basically make HDL less functional and can damage the arteries potentially. But I always look at more as a marker of gut health than anything. So I don't recommend people just give up fish and red meat and things like that. Initially, it's figure out what's going on with the gut microbiome. Maybe they just need to eat in a more circadian friendly way. Maybe they need to use photobiomodulation to help with gut health. So there's other things you can do, potentially probiotics maybe, but I don't dwell on it. So I mostly just make sure people are not supplement with a lot of acetyl carnitine if this level is checked and it's high. Question about apolipoprotein B. Their apoB is high, their insulin is low, which I would consider being under 5 low, 8 or less good. Blood pressure normal, which means less than 120 over 80, but optimal 110 over 70. How at risk are they? What other tests should they do? So it also depends, a little bit where apoB high is, but generally an apoB north of 70 is going to be the 20th percentile. An apoB of 55 is the 5th percentile, meaning 95% of people have values higher than that. So it depends on what the arteries are doing. So if you have endothelial dysfunction, if you have stiff arteries, if you have vascular inflammation on a carotid scan, if you have hard or soft plaque on a coronary scan, then you're going to modulate the apoB. There are lab tests that can tell you, what is driving it. Is it a hyperproduction issue of sterols? Is it a hyperabsorption issue of sterols? That's the cholesterol balance test that's done on the Boston Heart Lab panel. You also would like to know what your apoE as an echo status is, because that has an effect on how high apoB is at times, and what dietary interventions may or may not work for you. And then often, if it's high enough, it's going to be genetically driven, and there's up to 3,000 genes that affect lipoproteins. And the GB Insight, like Great Britain Insight panel, has about the best sensitivity at picking up some of these genetic markers that really affect lipoproteins negatively, and gives you a best idea of what treatment strategies to utilize. So it's a test don't guess philosophy, and you can figure out if you need to modulate it. Not everybody who has high apoB has to go on statin therapy, if that's what that question would be. Okay, so yeah, good question here. So somebody's asking, what do I think about the new research about the lean mass hyperresponders and high LDL? So I talked about this briefly in the AMA last week. I'm still waiting for the actual written paper to come out, but I did watch Dr. Budoff's presentation of the initial findings, where they're comparing the keto trial versus the Miami Heart trial. And it's not a completed study yet. They were just looking at patients who were on a keto diet who had the, quote, lean mass hyperresponder phenotype, and looking at, if they had more rapid plaque formation on a CT coronary angiogram than people who were not on that type of diet in that phenotype. But if you actually look at the numbers, the patients in the Miami Heart trial, their baseline LDL-C, and I know that by reading the study of the Miami Heart trial, they've actually collected the blood of these individuals, and they have apoB and they have the advanced markers, but it wasn't reported out in this initial study that they were released a couple weeks ago. But they're just looking at LDL-C, which is directionally accurate in some instances, but it's not the best predictor of risk. It's more apoB, or the LDL particle count, as I've talked about previously. But their baseline LDL-C was in the 120s. This is not an optimal level for somebody who has coronary atherosclerosis. So they're studying people who are not necessarily low risk versus people who had high LDL on a keto diet and had this lean mass hyperresponder phenotype. So just because the high LDLs in the 1 year, I believe, the patients were on the keto diet for 3 or 4 years before they got enrolled in it, they didn't have more advanced plaque in arteries. It just doesn't mean that high LDL is going to increase the plaque volume. but having any amount of plaque in the arteries is abnormal. So I don't think it was a fair study what they were looking at. So probably the people in the Miami Heart Trial had too high of LDL cholesterols at baseline to really compare them all. And it's also one of those things where it's like, now this is going a little bit of a rant here, it's like metabolically healthy, doesn't mean that your HDL and triglyceride ratio is normal. It means that your glycocalyx, lining your 60,000 miles of blood vessels is actually healthy. And if you don't test for it, you will never know. If you have a calcium score of 0, that tells you absolutely nothing about your endothelium. This tells you haven't damaged it significantly in the past, but doesn't tell you the health of it right now. So it's an interesting, phenotype. It's an interesting theory, but it does not mean that your arteries are not at risk with a super high LDL, and super high meaning an LDL-C greater than 190 milligrams per deciliter, which would normally look like familial hyperlipidemia. But more to come when they release more data. I'll keep you guys updated on it. Somebody's asking about what supplements they should consider adding for high cholesterol to avoid statins. So again, not medical advice, but best to use testing to figure out why your cholesterol is high to begin with. Is it a dietary intervention that you need? Cutting down on saturated fat, or improving your glucose concentration. So are you insulin resistant? Are you doing high quality exercise? Including strength training. Your muscles are your metabolic engines. Then, the cholesterol balance test on the Boston Heart panel tells you the statin's probably the better option for you. Or you're a hyperproducer. If you're a hyperproducer, statins work better. That's also a place where things like red yeast rice and bergamot work. That's also bempedoic acid, which is known as Nexletol, works. If you're a hyperabsorber, then that's where ezetimibe works. So the goal is just really getting the apoB down to the target based off of what the health of your arteries is dictating. So I have many patients who can't tolerate statins, or they just prefer not to take them, but you just have to get your goals in mind, and sometimes lifestyle interventions and supplements will get you the goal, but if not, then you got to figure out which pharmacological agent is going to work best for you. Question about zone 2 heart rate training. Is holding a conversation pace and a heart rate of 160 a concern? Not necessarily. It's going to depend on your baseline fitness status. Most of the time, zone 2 is easiest to keep your heart rate steady when you're biking or walking up an inclined treadmill. If you're a very fit individual, you could potentially actually run on flat ground and keep your heart rate in zone 2. But it depends on, what is your perceived exertion. So if you're a 5 out of 10 and you feel like you could keep that pace for up to an hour, then you're probably still in zone 2. But if you're feeling like this is harder, or you're starting to gasp for breath, you probably knocked yourself out of zone 2. So somebody's asking about the thoughts on niacin flush. It's due to the prostaglandins, and this is tied back into the questions that I asked earlier about niacin. If you don't flush with niacin and you get one of the quote flush-free niacins, the nicotinamide, that stuff doesn't actually work to affect your lipoproteins. So you have to take the full flush niacin if you want to have any effect on your lipoproteins. Now there might be other protocols that people are using for gut detoxes. I'm not talking about those, but for lipids, you have to be on the flush version. Somebody's asking about borderline dilated left atrium. They got trace mitral regurgitation and tricuspid regurgitation. Is there a way to reverse? Trace valvular disease of the atrioventricular valves is completely normal, and unless the pulmonary pressure is elevated, I wouldn't be terribly concerned about quote a borderline dilated left atrium. It actually depends on the left atrial volumes. The old school in-mode measurements aren't as accurate, but if you're using the LA MRTR, I assume this is a medical person who has some knowledge of echocardiograms. There's not a way to directly reverse it that I know of. I mean, keeping blood pressure optimized, doing things that improve mitochondrial function, probably would have an effect. So likely things like earthing, grounding, photomodulation, sonotherapy may have an effect on it, but nothing that I'd be terribly concerned about with that finding. All right. So it looks like speed rounds tonight. I think I got through all the pre-submitted questions, but I did see a few people popping in the comments some questions, so I'll see what we got here. Somebody's asking, why would a person's LDL be super low and a HDL be optimal levels? I mean, you could have an apoE2 allele, you could have a loss of function PCSK9 SNP. There's multiple genetic reasons why you could have super low LDL. So genetic testing with the GB Insight panel would likely point you in the right direction for that. What do I recommend to improve heart rate variability? Optimizing your sleep, controlling your circadian rhythms, thus sitting in the red light post-sunset. Making sure you're not overstressed in other areas of your life. So, if you have tons of mental stress or you're overtraining in the gym, you got to look at that first. But it would be looking at your trends of HRV more than just having a, quote, one-time low HRV. Also, sidebar on that is, what are you using to actually track the HRV? If it's one of these wrist-based monitors and you're using the PPG, basically the light therapy to evaluate it, that's not always as accurate. Heart rate variability is the measurement in milliseconds between consecutive heartbeats. So to really accurately measure it, you need to use a chest strap. And so I usually recommend either the Polar H10 strap, or if you want what I sometimes call the Ferrari of chest straps, that's the Frontier X2 strap. That has a continuous 1 lead EKG that you can actually stream to somebody to review your actual EKG. But it gives you strain loads. It just, it's overkill for most people. I got it because I'm sort of a gadget person, and especially if it's cardiovascular and testing your arteries or something, I definitely want to play around with it before, saying my patients should spend their money on these things. But monitoring your heart rate variability with a chest strap will give you much more idea if you actually have low HRV or not. Somebody's asking, am I a fan of calcium scoring? Absolutely. So, sorry, they just dehydrate from flying. Pretty much everybody. Unless you've had a heart attack, stroke, stents, or bypass surgery, you should be getting calcium scored at some point in your life. Now, I used to say start at 40. That was even earlier than most guidelines will say. But I really think probably 35 is probably the new cutoff point, because I've seen some individuals, just in my own practice, that under 40 has some very high scores for age. Now, calcium score of 0 is a good starting point, but it's not sufficient to tell you that you have healthy arteries. If it's abnormal, you're high risk. Start treating that high-risk individual. The follow-up question is, if your score is 0, 3 to 5 years later, repeat the scan and see is it still 0. But if your score is abnormal, I think I've gotten away from repeating the calcium score test on any type of routine basis. Because once it's abnormal, your goal is to try to stabilize the soft plaque. And oftentimes that soft plaque will calcify. And so if you use certain treatments, your calcium score test is actually go up. You're not necessarily getting worse, you're taking the soft vulnerable plaque and calcifying it and making it more solid. So if your score is abnormal, start treating. If it's 0, probably repeat it in 3 to 5 years. Somebody's asking how you can check how healthy your arteries are. It's a great question. I mentioned a little bit earlier, but I'm in the process of working on developing some protocols that you could do this at home with some of the wearables, and some of the lab companies you could do at home with finger pricks testing. If you see me in my office at apolipoprotein, we have all the toys to test your arteries. So kind of go head to toe, salivary nitric oxide test strips, carotid endomedial thickness scans, pulse wave velocity. There's various devices. We use a max pulse. At home, you can use the iHeart monitor. The endopat test is a non-invasive test telling you how much nitric oxide your arteries can release. I just mentioned the calcium score test, which is a low-dose CT scan. If you want the kind of gold standard to look at the actual artery walls, that's going to involve doing a CT coronary angiogram, and then you can have the images sent off to Clearly for a machine learning AI interpretation of the images to tell you, do you have soft plaque, very low density soft plaque, or hard plaque. And so, those are the ways to really tell you how healthy your arteries are. And there's a whole battery of lab tests, but I think you're talking about how to actually measure it. One thing I did mention is just blood pressure is a good one. If your blood pressure is over 120/80, there's something going on with your arteries and you need to figure out why that is. leads in this question. Somebody's asking about blood pressure. So the diastolic pressure, which is the lower number, will not lower on lisinopril hydrochlorothiazide. But when they add propranolol, their number falls to normal. I mean, everybody has different genes that affect which medications tend to work better for blood pressure. You know, I often talk about like blood pressure is not truly a disease. It's something in your environment causing your arteries to constrict, and you got to figure out what that is and try to remove that variable. But when I say like propranolol helping, that tends to mean it's going to help, you know, blocking certain stress hormones. So it may have been more of a adrenaline type of response where your arteries are constricted. And the best way to kind of really test is doing a 24-hour blood pressure monitor to figure out what your average systolic and diastolic pressures are. Do your systolic and diastolic pressures both drop while sleeping? That's called dipping status. And then there are various testing. You know, I tend to like the Vibrant America Cardiac X panel to really tell you which gene you may have that affects your blood pressure. Often people have 5 to 10 genes affecting their blood pressure, but that gives you which medications often work better to control your blood pressure. This is too challenging to answer fully in this type of setting, but somebody says, what is the most beneficial diet for heart and artery health? It's really, you know, individualized to the person. You know, I'm going to start with what is your maternal haplotype? So where did your mitochondria come from? Where do you physically live in the world? What are your health goals? You know, what time of day are you eating? You know, are you getting high quality dietary protein to help your muscles recover and build more muscle units? Because it's your muscles that are metabolic engines that are going to be burning the glucose and the fats for the most part. So multiple diets can work for people, but it really depends on some of those metrics I just mentioned. Somebody's saying that they're on Zocor or he's been on Simvastatin. It's not really working anymore. Their numbers are high. Simvastatin just stopped working. And as an athlete with a healthy diet, it's a bit surprising. So again, there's over 3,000 genes that affect lipid metabolism. Some of them, you know, can indicate like which medications work better for people. Simvastatin, you know, tends to be fairly potent, especially when you're getting at the higher doses. But there are more potent statins, if need be, to utilize to continue to dial back on the apoB. But often, you know, instead of trying to jack up the statin to the highest dose, it's better to do synergistic therapies and consider adding on ezetimibe or adding on a PCSK9 inhibitor to help support the LDL receptor. And then, you know, that may be a little bit more beneficial, especially for athletes, because the biggest concern is, you know, the statins causing muscle symptoms, you know, fatigue or pain in the muscles, and you want to just, you know, lower your cardiovascular risk but not affect your athletic performance. So, again, somebody's asking about, you know, kind of a personal question, you know, in generalities, if you have a history of cardiovascular disease, would I recommend a Mediterranean diet better than a keto diet? Now, it always depends, but the literature would tend to support in all comers a Mediterranean diet is probably more health promoting, but I would want to know those, you know, metrics I mentioned earlier, and then just have a very, you know, comprehensive, you know, advanced lab panel in front of me that says, like, whatever diet you're currently doing, is it working for you metabolically? If your blood pressure is low, does it mean that your arteries are unhealthy? No, it generally means they actually are healthy. There is no true definition of low blood pressure per se, you know, but if your systolic blood pressure is less than 90, you know, and then especially if you're symptomatic, if you're dizzy, lightheaded, fatigued, have exercise, you know, intolerance, then a low blood pressure is a problem. But that is not super common, and there's some reasons why people have some autonomic dysregulation that affects that. But, you know, a normal blood pressure should be 110/70 without medications. All right, so how would I treat a calcium score less than 100? Figure out what's causing the endothelial dysfunction, treat any oxidative stress or inflammation, and look at what your lipoproteins were, you know, baselines are at. So what is your apolipoprotein B? If it's greater than 70, shoot for that as the target. Yes, indeed. Adrenaline constricts your arteries so that blood flow gets to where it needs to go, and you can run away from the tiger that's chasing you. All right. So I got through the questions. I apologize again for the slight delay. I was saying I just got back from Dr. Lyon's Forever Strong event, and Austin was outstanding. If you guys haven't read her book, Forever Strong, it really kind of has the roadmap on how to age well, and her focus is on muscle-centric medicine. You have to have healthy muscles to age well, and so it's very complementary to what I'm talking about here, having healthy endothelial function, healthy arteries. So, we all focus on longevity, but it's really about health span, your day-to-day well-being. So lift some heavy stuff, get your arteries checked out, and go out there in the world and do the things you want to do. Next week, I'll actually be doing a little bit of traveling, so I'm not going to be doing anything on Monday night. I'll probably do it later in the week, tentatively probably be Wednesday. We'll keep it at the same time though, so probably Wednesday, 6 p.m. Central Time, we'll do another one of these things and answer any questions that you got. I have a lot of ideas on how to start doing some more long-form content, more likely to be on my YouTube channel. And again, my YouTube channel will be YouTube at Dr. Twyman. So I'll probably do some videos that will go through some of these testings that we talked about, such as the endothelial function test, the pulse wave velocity testing, CIMTs, clearly scans, calcium scores. I'll do more kind of like, what the videos truly, show will be like how the testing's done and what the results mean. We'll also start doing some testing with some of these wearables. I have a lot of toys at home, so I'm kind of trying to calibrate them, see how well they work against some of my non-invasive testing I have at my office at apolipoprotein. So if you guys have any questions in the meantime, just leave them in my DMs, and I appreciate your guys' time and attention. We'll see you next time.